The next form will be Form A, the patient data. Again, we're showing you a filled-in example. Again, here you will fill in the hospital code for our site 123. Then you will fill in the ward name for which you may recognize ICU-1 as being the first ward that was on our ward list. In this case, this is the first column of our ward list, and you will fill in the corresponding ward specialty from the codebook, which is the third column in our list. Then you will fill in the survey date, in other words, the date at which the data was collected. Per ward, this should only be 1 day, and so you will fill in the specific day, in our case, the 8th of August. The next field is the patient counter. This can only be numbers, which means you cannot add letters. For instance, the hospital patient code, which is often containing the letter A or B or some letter of the name, will not be able to be used here. It can only. We decided to fill in our example for an 80-year-old male who was hospitalized on the 22nd of July 2011. Next, you will fill in the consultant patient specialty. This is the specialty of the doctor who is treating the patient. This can differ from the ward specialty. In other words, if you have a patient of a certain ward who's being treated by a doctor from a different specialty, this is the place to mark it. You can, for instance, have a geriatric ward with a patient that is being treated by a physician of infectiology. The code book is the same list for these two. In other words, there's only one list that you need to use to code the specialty of either ward or consultant. Next fields will be the surgery since admission. There are four possibilities: no surgery, NHSN surgery, minimal invasive non-NHSN surgery, and unknown. The third category, being the minimal invasive non-NHSN surgery, might be new to some of you. In the codebook, the last pages, this is clarified as it is in the protocol, the difference between NHSN and non-NHSN surgery. The McCabe score is a score that is used to classify the patients according to comorbidities. Terms that non-fatal disease, the patient will not die within 5 years, ultimately fatal within 1 to 5 years the patient will die, and rapidly fatal the patient will die within 1 year. It's important to understand that the McCabe score does not take into account the current condition. For instance, our patient who was hospitalized on the 22nd of July should actually be McCabe scored just before this current episode. For instance, a patient that has as a comorbidity heart problems and diabetes, but is currently being treated for a CVA, then the patient should only be McCabe scored on the diabetes and the heart problems. The next fields are risk factors. Please note whether the patient has a central vascular catheter, a peripheral one, a urinary catheter, or is intubated. The last two fields will determine whether or not you fill in the next part of this patient form. We haven't stated it before, but it is important to realize that every patient that is included in the PPS will have one Form A filled in. The difference is that if it is a patient that is not taking antimicrobials and does not have an active healthcare-associated infection, then only the left side of the form will be filled in. If the answer to one of these two questions is yes, also the corresponding part of the right side will be filled in, the top part for antimicrobials and the bottom part for HAI. We've decided to give our patients both antimicrobials and active HAI. And we will discuss the antimicrobials first. There are 5 fields that you will need to fill in for each antimicrobial the patient is taking. The first is the generic name. Although it's stated above this column that you can also fill in the brand name, the HelixWin-Net current version only allows you to code generic names. Therefore, we strongly advise that you already fill in the generic names when doing data collection. However, nothing would be stopping you from doing the brand name during data collection and transforming it to the generic name when encoding it. Next, you will be asked to fill in the route, which is coded under the table, the indication, which is equally coded under the table. In our case, we've decided to give our patient a community-acquired infection. The fourth of these variables is the diagnosis. For this, you will need to use the codebook. The last of the variables is whether or not the reason for taking antibiotics is described in the patient notes. A simple yes or no will suffice. The bottom part of the form A will describe the HAI the patient has. In other words, you only need to fill this in if indeed yes is marked. We gave our patient a PN1, a pneumonia type 1. This is obviously an HAI code that you will find in the codebook. There are 3 HAI codes for which you will be asked if there is a relevant device in situ before the onset. These are marked underneath the table. It is pneumonia, in which case intubation is a relevant device, bloodstream infection, for which CVC is a relevant device, and urinary tract infection, for which urinary catheter is a relevant device. In these cases, if you have marked one of these 3 as an HAI code, you may fill in whether or not that specific relevant device was present in the 48 hours before onset, or in the case of urinary tract infection, in the 7 days before onset. Then you will be asked whether or not the HAI was present at admission. In our case, we marked no. If you mark no, you will then be asked to fill in the date of onset, or at least the estimated date of onset. In our case, this was the 28th of July. If you mark yes, you will not fill in the date. Next, you will be asked to fill in the origin of the infection. Although there are three possibilities, being the current hospital, an other hospital, and an other origin, theoretically you will use only one of the first 2, being a current hospital or other hospital, because the healthcare-associated infections in the PPS are only healthcare-associated infections from an acute care hospital. Next, the BSI. If you've coded the case definition BSI, then you will be asked to fill in the source. Again, this is coded in certain ways, which is marked underneath the table, but also in the codebook and the protocol. It may be important here to remark that in the specific case of CRI-3, which is a catheter-related bloodstream infection, you will not have to mark the source. In other words, if you mark CRI-3 here, you will not fill in the source. This is because the source is already implied in the CRI-3 code. Only if you actually mark the actual code BSI will you be asked to fill in a source here. The last part of this field is the microorganism. The protocol clearly describes when you will be filling in this field. In our case, the patient has a Staphylococcus aureus, which is coded in the way that you see it. For certain of the microorganisms, you will also be asked to give a resistance code. This is not valid for all microorganisms. In the codebook and the protocol you will find which exactly you will need to reply resistance code for. It's a numeric code, mostly 1, 2, or 3, or 9, and you will find in the codebook exactly which one it is. In our specific case, the resistance code is 1, which means that the Staphylococcus is actually an MRSA. This is the last of the information that we needed to collect, and the next part of this film will discuss data entry into HelixWNet.